Hello everyone, I am myself Dr. Rajesh Guba. In this particular session, I'll be discussing a very important topic in the cardiology, that is the hypertrophic cardiomyopathy. So, hypertrophic cardiomyopathy, it is one of the very important etiology where the individual can have a sudden cardiac death. And usually the history will be in such a way key, like there will be a family history of sudden cardiac death upon doing the exertional activity, right? Or the mother will be complaining that the father of the individual, the patient, has died while playing the football. That is what the mother will be bringing the son to the doctor, and that will be the usual history. And if at all, if they are symptomatic, the most common symptom will be the dyspnea. And the other symptoms that you will have in patients with the hypertrophic cardiomyopathy is they can have angina, they can have dizziness, they can have syncopal attack, and they may also land up in the congestive heart failure. So this will be usual presentation in case of hypertrophic cardiomyopathy. And on examination, they will have a characteristic pulse called pulsus bisferiens. They will have double carotid upstroke. Then double apical impulse will be there. And upon auscultation, you will have an additional heart sound, that is S4. And you have a classical murmur, that is ejection systolic murmur. So this will be the examination findings in patients with the hypertrophic cardiomyopathy. Now, usually, this hypertrophic cardiomyopathy, it is acquired to the individual through inheritance. Okay, the familial forms is most common, and the type of inheritance is the autosomal dominant type of inheritance. And you need to know what is the etiology for the development of this hypertrophic cardiomyopathy. It is mainly due to mutation of genes. That is what is responsible for the hypertrophy in case of hypertrophic cardiomyopathy. Now, what is the criteria to call it as the hypertrophic cardiomyopathy? See, the criteria is that whenever you do a 2D echo, the 2D echo should be showing the increase in the LV wall thickness more than 1.5 centimeter. So that's a very, very important criteria. Either the hypertrophy is in the septum, or the hypertrophy can be at the apex, right? Wherever might be the hypertrophy, the increase in the LV wall thickness should be more than 1.5 centimeters on echocardiogram. That is what is the criteria for the hypertrophic cardiomyopathy. But whether the obstruction will be there or the obstruction will not be there for left ventricle completely depends upon the site of the hypertrophy. Like, for example, if the hypertrophy, if it is at the septum, this septal hypertrophy will cause the obstruction to the LV outflow tract. So here, the hypertrophy septum, because it is causing the obstruction to the LV outflow tract, this is also called as hypertrophic obstructive cardiomyopathy. Whereas you take here, the apex is being hypertrophied, and the apex which is hypertrophied is like more than 1.5 centimeters. That is what we have discussed the criteria. But here, there is absence of the LV outflow tract obstruction. So this is just called as the hypertrophic cardiomyopathy. Okay. And the hypertrophy, whatever you're having in case of the hypertrophic cardiomyopathy, it occurs in the absence of a causative hemodynamic factors. That means there is no hypertension. Usually hypertension is the one which will cause left ventricular hypertrophy. But in spite of absence of hypertension, there will be hypertrophy, right? Or there will be no aortic valve disease, right? Usually it is the aortic valve pathology, that is aortic stenosis or aortic regurgitation, that will be causing the hypertrophy. But in spite of absence of aortic valve disease, there is hypertrophy in case of the hypertrophic cardiomyopathy. And there is also absence of infiltrative or storage diseases. Because usually you take the infiltrative disorder which can cause increase in the thickness is in case of hemochromatosis. But in spite of absence of any infiltration, there is hypertrophy in case of the hypertrophic cardiomyopathy. So this hypertrophic cardiomyopathy, previously what it was termed as, the hypertrophic obstructive cardiomyopathy, or the another name is asymmetrical septal hypertrophy, because the septum which is hypertrophied, it is not symmetrically hypertrophied. It is only the base of the septum which is getting hypertrophied. So that is the reason why it is called ASH, asymmetrical septal hypertrophy. Or the another name which is given is idiopathic hypertrophic subaortic stenosis. Okay, that is IHSS, right? What does this IHSS stands for? Idiopathic hypertrophic subaortic stenosis. So these are the why, because the hypertrophy of the septum, whatever is there, it is present just beneath the aortic valve. That is the reason why it is called subaortic stenosis, right? And that too, it was considered to be idiopathic because there is no hypertension. There is no aortic valve pathology. There is no infiltrative pathology causing hypertrophy. So that is the reason why previously it used to be considered as idiopathic hypertrophic subaortic stenosis. However, this particular terminology is not being used these days. So what is being used these days? It is the hypertrophic cardiomyopathy with or without obstruction. Right? With or without obstruction. So this is the terminology which is being used recent days. So if there is an obstruction, that would be because of septal hypertrophy. If there is no obstruction, it would be the apical hypertrophy. Now, if you take the shape of the LV lumen in case of the apical hypertrophy and as well as the septal hypertrophy, in apical hypertrophy, the shape of the LV lumen, it is considered as the ace of spades. That is the shape of the LV lumen in case of the apical hypertrophy. Whereas you take in case of the septal hypertrophy, the shape of the LV lumen, we call it as a banana shaped left ventricle. Okay. So you can just observe here. So this is the banana shaped left ventricle. So this you have in case of the septal hypertrophy. Whereas ace of spades, you will have that in case of the apical hypertrophy. Now, let me tell you a few differences between the septal hypertrophy and as well as the apical hypertrophy. First and foremost, just now we were discussing about the shape of the LV lumen. In septal hypertrophy, it is the banana-shaped left ventricle. Whereas in apical hypertrophy, the shape of the left ventricle will be in the form of ace of spades. Right? In the form of ace of spades. Now, you take inheritance. Both of them, the type of inheritance is autosomal dominant type of inheritance. There is no change in that. But in how many percentage of individuals it is the inheritance causing septal hypertrophy? Like in almost 50% of patients. So the familial inheritance it is more common in case of the septal hypertrophy. But the familial inheritance in case of the apical hypertrophy is less. Okay? It is less often. And if you take the percentage also, you take in case of the septal hypertrophy, the mutation, it occurs in almost 50% of individuals. Whereas in apical hypertrophy, the familial disease or the familial inheritance is less common. And what is the percentage in case of the apical hypertrophy? It is just only 15%. So, which form of hypertrophy, like where there is most commonly inherited? That is your septal hypertrophy, right? Then what about the obstruction? Obstruction, it is present where at the left ventricular outflow tract. But whereas in apical hypertrophy, the obstruction, it is absent. And in septal hypertrophy, as the word itself tells you, it is the base of the septum which is hypertrophy in case of the septal hypertrophy. Whereas in apical hypertrophy, it is the apex which is being hypertrophy. So these are the differences between the septal and as well as the apical hypertrophy. And very, very important point is the obstruction. The obstruction will be there only in case of septal hypertrophy, but absent in case of the apical hypertrophy. And this obstruction, whichever is there in case of the septal hypertrophy, the obstruction is present at rest in almost 30% of patients. Right? Obstruction is present in almost 30% of patients at rest. But whereas this particular obstruction, it is provoked by exercise. Right? Obstruction is provoked by exercise in the other 30% of patients. Okay, so overall in 60% of individuals, there will be obstruction that is in provoked state. So that is about your septal hypertrophy. Like what is the chance of the obstruction? Now, this septal hypertrophy, it is characterized by the dynamic outflow tract obstruction. Right. So this septal hypertrophy, it is characterized by dynamic outflow tract obstruction. Now, what do you mean by the word dynamic outflow tract obstruction? So when the left ventricle is about to contract, initially, right? So in the initial part of the LV contraction, there is no obstruction. Right? There is no obstruction in the initial part of the LV contraction. But exactly in the mid-systole, right? Exactly in the mid-systole, there will be the obstruction which will develop. And the obstruction, whatever you are seeing in the mid-systole, that is due to systolic anterior motion of mitral valve leaflet. Right? That is, SAM stands for systolic anterior motion of the mitral valve leaflet. And in order to overcome this obstruction, the LV contracts forcibly, then the obstruction disappears again. So, or obstruction reduces. So now the obstruction, whatever is there, it is not present throughout your left ventricular systole. It is present only in the mid part of the systole. And that is due to SAM, systolic anterior motion of the mitral valve leaflet. And that is what is called as the dynamic outflow tract obstruction. And this hypertrophic obstructive cardiomyopathy, please remember, this is one of the leading cause of sudden cardiac death in young individuals. And it is also one of the very, very important cause for the heart failure. And if you see the pathogenesis for hypertrophic cardiomyopathy, it is mainly because of the gene mutation. And because of the gene mutation, there will be abnormality within the sarcomere. That is, sarcomeric mutations will develop. Now, if you take the number of genes which are being mutated, the number of genes which are being mutated are, there are totally 9 different genes which are being mutated. And the number of mutations will be more than 1500 mutations will be there in this 9 different genes. Now, you need to know what is the most common gene which is being mutated. That is MYH7. So this MYH7, it stands for beta-myosin heavy chain. Right? Beta-myosin heavy chain. So this is like the most common mutation what you come across in hypertrophic cardiomyopathy. And the other genes which are being defective is MYBPC3. What does this MYBPC3 stands for? That is myosin binding, right? Myosin binding protein C. Okay, myosin binding protein C. So that is what is the another important gene which is being mutated, but it is most commonly it is beta myosin heavy chain, and subsequently it is myosin binding protein C. And the type of inheritance, as I have said you in the beginning also, it is autosomal dominant type of inheritance. Now, because it is a disorder where you have a familial inheritance, so screening, and that too autosomal dominant type of inheritance. So screening of the family members, it should begin in adolescent and it should be extended through the adulthood. So in adolescent age group, the screening of the family members should begin. And in case of myosin binding protein C mutation carriers, the average age of the disease development, right? The age of the disease development is around 40 years. Right? It is around 40 years. But almost 30% of the patients, they remain free from hypertrophy even after 70 years also. But most commonly, it is around 40 years where the hypertrophy starts developing, right? And sudden death and as well as progression to the heart failure occur more commonly, right? Occur more commonly in individuals with family history of sudden cardiac death. So those individuals who have the family history of sudden cardiac death due to hypertrophic cardiomyopathy, in them, the chance of sudden cardiac death and progression to heart failure is also very, very common, right? Now, so basically it is the sarcomeric mutation due to genes which are being mutated. Now, what are the changes that occur at the level of the sarcomere. So at this level of the sarcomere, hypertrophic cardiomyopathy mutation leads to, number one, increased calcium sensitivity, right? Where the calcium handling is being affected. There is maximal force generation and the ATPase activity gets affected. So these are the changes that occur at the level of the sarcomere, right? And this sarcomeric mutation, so these changes, right? These changes, they lead to abnormal energetics. Right? They lead to abnormal energetics and there will be impaired relaxation of the myocardium. Right? Impaired relaxation of the myocardium. And why this impaired relaxation of the myocardium? That is because of the hypertrophy of the myocardium. Impaired relaxation is mainly because of the hypertrophy. So, if you take the biopsy in the autopsy studies, when you examine this under the microscopy, like how maybe the hypertrophic cardiomyopathy appears. So, you will notice that there is characteristic disarrayed myocyte architecture with swirling and as well as the branching. So, you can see that. Okay. So, the parallel structure is completely lost and there will be swirling. So, microscopic image of hypertrophic cardiomyopathy shows the characteristic misalignment and disarrayed myocyte architecture with swirling and branching rather than usual parallel arrangement of the myocyte fibers. And not only the myocyte fibers, even you take the myocyte nuclei. Right? So even if you see the myocyte nuclei, they are also markedly increased in its size. And you will also notice the interstitial fibrosis. Right? You will also notice interstitial fibrosis. So this is what is the biopsy picture that will be seen in case of the hypertrophic cardiomyopathy, where there is misalignment and disarrayed myocyte architecture. The nuclei size vary. The parallel architecture is lost and there is also the interstitial fibrosis, right? Now, if you take the overall pathology of the heart, what are all the changes that will appear within the heart? So there will be hypertrophy, interstitial fibrosis, microvascular ischemia, and there will be the scar formation. So this hypertrophy is the defining feature of the hypertrophic cardiomyopathy. So this is the important feature or important pathological change that occur in hypertrophic cardiomyopathy. And subsequently, there will be fibrosis and as well as the microvascular disease is also being present. Now, you take this interstitial fibrosis. Interstitial fibrosis is detected or it is detectable before the overt hypertrophy develops. And why is that you will have the interstitial fibrosis before the overt fibrosis? See, this is because of early activation of pro-fibrotic pathways. Right? So, due to early activation of pro-fibrotic pathways, there is the interstitial fibrosis, right? And how will you diagnose this fibrosis within the myocardium, right? These focal areas of the fibrosis can be easily detected by the MRI, right? Then the next important change is the microvascular ischemia. So what is happening to your myocardium? There is increased thickness of the myocardium and there is decreased luminal area of intramural vessels. So there is decreased intraluminal area. And there is also increase in the thickness, right? So this increased thickness and decreased luminal area of the vessels in hypertrophied septum, that will contribute to the ischemia, right? That will contribute to the ischemia. And because of ischemia, there will be development of angina, right? Because of ischemia, there is development of the angina, right? And next is the scar formation. So there is like the infarction because of ischemia, right? There can be the infarction. There will be micro infarction of the hypertrophied myocardium. So this micro infarction of hypertrophied myocardium, right? Micro infarction of hypertrophied myocardium, that is what is responsible for the scar formation. And the scar, whichever has been formed, that is a substrate for the development of the VT or VF. Right? It is a substrate for the development of VT or VF. So these are the various changes within the heart in case of the hypertrophic cardiomyopathy. So definitely the very, very important changes, the hypertrophy. Followed by that, the interstitial fibrosis will be there. That is due to the activation of the profibrotic pathways. And you can detect that fibrosis even by MRI as well. And subsequently, there will be microvascular ischemia and as well as angina. And that is due to decreased luminal area of the intramural vessels in hypertrophied myocardium. And this ischemia, subsequently, it can progress to the microinfarction of the hypertrophied myocardium, right? And this microinfarction of the hypertrophied myocardium, that is what has been hypothesized for the formation of the scar. And these areas of the scar may represent the substrate for the development of the VT or VF. Now, very important thing is, in case of the hypertrophic cardiomyopathy, is it like systolic or is it diastolic dysfunction? Remember, initially, you will have the diastolic dysfunction itself, right? So, this diastolic dysfunction is mainly because of the fibrosis of the myocardium, right? Or it is due to hypertrophy of the myocardium, right? It is due to hypertrophy of the myocardium, right? And why there can be development of the contractile dysfunction, right? It is predominantly diastolic dysfunction only, but there can also be the contractile dysfunction as well. That is nothing but the systolic dysfunction. Why is that? That systolic dysfunction is due to microvascular ischemia, right? That is due to microvascular ischemia. So that is the reason why ejection fraction will not be absolutely normal in patients with the hypertrophic cardiomyopathy. The ejection fraction is around 40 to 50% in these patients with the hypertrophic cardiomyopathy. So these are the pathological changes and pathogenesis in hypertrophic cardiomyopathy. Now you need to know the clinical features. See, most of these patients, they are asymptomatic and they directly present with the sudden cardiac death. Okay, they directly present with the sudden cardiac death. And if at all, if they are symptomatic, the most common symptom will be the dyspnea, right? If at all, if they are symptomatic, the most common symptom will be the dyspnea, right? And this dyspnea, it is present in almost 90% of the patients. Now, what is the mechanism of the dyspnea? See, the mechanism of the development of dyspnea is mainly because of the diastolic dysfunction. Okay, so this dyspnea is largely a consequence of elevated diastolic filling pressure. Okay, so that is due to increase in LV-EDP, right? And this increase in LV-EDP will be reflected back into the left atrium, thereby left atrial pressure is elevated, and subsequently the pulmonary venous pressure is elevated, and subsequently the pulmonary capillary wedge pressure is elevated, causing the pulmonary edema, right? Causing pulmonary edema. So this is what is the mechanism of dyspnea in patients with the hypertrophic cardiomyopathy. And the other important is they will also have the pre-syncopal attack. That is, they will have graying out spells, or they will develop this graying out spells. So this graying out spells, it occurs when the individual acquires the erect posture. Now, what is the reason? The reason is that in these individuals with hypertrophic cardiomyopathy, whenever the individual stands, what will happen to venous return? So in the erect posture, the venous return decreases. When venous return decreases, what will happen to your LV lumen size? The LV lumen size decreases. Once the LV lumen size decreases, what will happen to the obstruction? If it is hypertrophic obstructive cardiomyopathy, the obstruction increases. Once the obstruction increases, the cardiac output decreases, and thereby there will be decrease in the cerebral perfusion, and that can be responsible for the development of the pre-syncopal attack. And this pre-syncopal attack, let me tell you, it is relieved, right? It is relieved by lying down, right? It is relieved by lying down. So that is about the pre-syncopal attack. And the next important is the syncopal attack. So the syncope, it occurs from inadequate cardiac output, right? It occurs from inadequate cardiac output or from the cardiac arrhythmia, right? Or from cardiac arrhythmia. So that is what is responsible for the syncopal attack. And this cardiac arrhythmia, it could be your VT or VF. And that will cause hypotension, decreasing the cerebral perfusion, causing the syncopal attack. But what you have to remember is, those individuals who presents with syncopal attack, they are the candidates who are at high risk of sudden cardiac death, right? Who are at high risk of sudden cardiac death. And another important feature is the angina, right? So the typical symptoms of angina, they occur due to impaired diastolic relaxation, right? There is decreased diastole, okay? Right? Impaired diastolic relaxation, and there is also markedly increased myocardial oxygen demand. Right? There is markedly increased myocardial oxygen demand. And this increased myocardial oxygen demand, that is due to the ventricular hypertrophy. Right? That is due to ventricular hypertrophy. So, now, once there is ventricular hypertrophy, but there is decreased diastolic relaxation, but how is the supply to the myocardium? Reduced. So that will result in subendocardial ischemia. And the subendocardial ischemia is the one which is responsible for the development of the angina. Okay. So the typical symptoms of angina, it occurs due to impaired diastolic relaxation and markedly increased myocardial oxygen consumption, which is caused due to ventricular hypertrophy that results in the subendocardial ischemia. And the next important feature is the palpitations. And these palpitations are mainly because of development of the arrhythmias. And the arrhythmias that you can come across is not only your ventricular arrhythmias. There can be atrial fibrillation, there can be ventricular premature contracture, and there can be even the ventricular tachycardia. And even not only atrial fibrillation, there can be even the development of the atrial flutter. What exactly is the mechanism? I will discuss. But for VT or VPC, already I have discussed, it is the scar formation. That will be the scar which is being formed because of the microinfarction. That is what is arrhythmogenic, and that will result in your VT or VPC, and where the patient will present in the form of the palpitations. And another important symptomatology is the dizziness. So dizziness is common in hypertrophic obstructive cardiomyopathy patients with elevated pressure gradients across the LV outflow gradients. Okay. So this dizziness, it occurs mainly whenever there is decrease in the preload, right? Or when there is increase in the afterload. So both of them, they will increase the gradient across left ventricular outflow tract. And this gradient, whichever is increased across the LV outflow tract, will cause decreased cardiac output, right? And thereby cerebral perfusion can be reduced, causing dizziness. It is almost similar to that of your pre-syncopal attack. And finally, the congestive heart failure. So this congestive heart failure, it is relatively uncommon, but it can occur in severe hypertrophic obstructive cardiomyopathy. And it is predominantly the diastolic heart failure, right? Only in case of the severe form of hypertrophic obstructive cardiomyopathy, there can be development of the congestive heart failure. So now you see, most common symptom, it will be dyspnea. But most common presentation will be in the form of the sudden cardiac death, right? And what would be the reason for sudden cardiac death? These individuals, whenever they do the exertional activity, the myocardial oxygen demand will be increased, but the supply will be reduced. And upon exertion, that scar, it may become arrhythmogenic, and where there can be VT or VF, where the individual will develop sudden cardiac death. Okay, right. Then coming to the examination findings in patients with the hypertrophic cardiomyopathy. So the pulse is the characteristic pulse, that is Bispherians pulse, right? And what do you mean by the word pulses Bispherians? Where you have two peaks during the systole, right? Which we have discussed in detail about the mechanism of the pulses Bispherians in the topic of the arterial pulse. And how will be the carotid? There will be double carotid upstroke, right? There will be double carotid upstroke. And what is the mechanism? So initially, the left ventricle will try to eject the blood into the aorta rapidly, but because of SAM, in the middle of the systole, the ejection reduces, and in order to overcome the obstruction, left ventricle will further contract very strongly. Again, the ejection increases. So thereby, you will have a double carotid upstroke. And the apical impulse also, it is the double apical impulse. Now, why is that you will have double apical impulse? The reason or the mechanism is that if you observe here, that there is the hypertrophy. So what will happen to your LV end diastolic pressures increases? When LV end diastolic pressure increases, the left atria, it has to contract very strongly. And that stronger left atrial contraction is being felt as the apical impulse as well. Definitely, you have the apex of the left ventricle contraction, you will feel it as one apical impulse, and the stronger left atrial contraction you will feel as the another apical impulse. That is the reason why it is called double apical impulse. The auscultation along with S1 and S2, you will have an additional sound, the S4. Usually, you don't listen S4. If at all, if you are listening S4, it is a pathological heart sound. And what is the mechanism of development of S4? That is due to atrial contraction. But how is the atrial contraction in patients with the cardiomyopathy? It's a stronger atrial contraction. Why? Because the LV end diastolic pressure is increased. So when the contraction of the atria is very strong, then you will listen this pathological S4, right? You will listen this pathological S4. And the characteristic murmur. So if you take the characteristic murmur, it is a harsh ejection systolic murmur. But this ejection systolic murmur of hypertrophic cardiomyopathy, right, it does not radiate to the carotid, right? What are the other conditions where you can have a harsh ejection systolic murmur? That is in aortic stenosis. But aortic stenosis, harsh ejection systolic murmur will radiate to the carotid, but hypertrophic cardiomyopathy, the ejection systolic murmur, that will not be radiating to the carotid. And if you describe the shape of the murmur, it is a diamond-shaped murmur. Right? It is a diamond-shaped murmur. Okay. So that is about the auscultation. But you need to know the dynamic auscultation of the murmur. So what you have to remember is the intensity of the murmur, it increases whenever there is increase in the obstruction. And when will the obstruction increase? The obstruction increases whenever there is decrease in the LV lumen size. Right? So you can see that here. Whenever the LV lumen size decreases, the hypertrophied septum, it comes very nearby the anterior mitral leaflet. So the obstruction increases whenever there is decrease in LV lumen. So whenever the obstruction increases, the intensity of the murmur also increases. And where will the intensity of the murmur decrease? That is, when the obstruction decreases, then the intensity of the murmur decreases. And what are the conditions where the obstruction decreases? That is, whenever there is increase in the LV lumen size, the obstruction decreases. So once the obstruction decreases, the intensity of the murmur also decreases. Now, let me tell you the maneuvers or the conditions where the murmur increase and the murmur decrease depending upon the concept what we have discussed. So you take the conditions where the murmur increases. So in order to increase the murmur, what should happen to the obstruction? It should increase. Now, what are the conditions where the obstruction increases? So the obstruction increases whenever there is decreased preload to the left ventricle, right? So what are the conditions where there can be decreased preload? That is in Valsalva, right? When the individual is doing Valsalva maneuver, then sudden standing, there will be decrease in the venous return. Thereby, the preload decreases, the LV volume decreases, obstruction increases, and the murmur increases. And when the patient is given nitrates, that is nitroglycerin or diuretics. So nitroglycerin or diuretics also, they decrease the preload. Thereby, the obstruction increases, the intensity of the murmur increases, right? And the another conditions where the intensity of the murmur can increase is during the exercise. So during the exercise, there will be massive release of catecholamines. Catecholamines, they increase the contractility. So LV lumen size decreases, obstruction increases, intensity of the murmur also increases. And next is when the individual is on or taking the cardiac glycosides. Again, the same thing. Cardiac glycosides also will increase the contractility. The LV lumen size decreases, obstruction increases, intensity of the murmur also increases. And next is the sympathomimetic amines. Okay, so even your sympathomimetics, they increase the LV contraction, LV lumen decreases, obstruction increases, intensity of the murmur increases. So that is the reason why, remember this point, that these drugs, that is nitrates, diuretics, cardiac glycosides, and sympathomimetics, they are contraindicated. Why are they contraindicated? Because they increase the obstruction. So LV outflow decreases. So that is the reason why they are contraindicated in patients with the hypertrophic obstructive cardiomyopathy. But this diuretics you need to give cautiously if the individual develops pulmonary edema, right? Next, you need to know the conditions where the intensity of the murmur decreases. In order to see that the intensity of the murmur decreases, the LV volume should increase, the obstruction decreases, then the intensity of the murmur decreases. So what are those conditions? Like when the individual is made to lie down in supine position, and when you do a passive leg rising, right? When you do a passive leg rising, then squatting position. So in these conditions, the venous return increases, the LV volume increases, obstruction decreases, and the intensity of the murmur also decreases. And the conditions where there can be increase on the afterload, that is upon doing sustained hand grip. Right? There can be increase in the afterload. So LV volume increases, the obstruction decreases, and the intensity of the murmur also decreases. And the drugs which can decrease the intensity of the murmur is beta blockers and then the calcium channel blockers. So beta blockers and calcium channel blockers, by decreasing the contractility, the LV volume increases, obstruction decreases, and the intensity of the murmur also decreases. So this is about the dynamic auscultation in case of the hypertrophic obstructive cardiomyopathy. Then how will you diagnose these cardiomyopathies is the next very, very important point. One is the ECG. So ECG, it will show you the features of the left ventricular hypertrophy. And you will have this characteristic LV strain pattern. So what will be the characteristic LV strain pattern? You will have the T-wave inversions in the lateral leads. right? Then followed by that, you have the presence of the deep Q waves, which we call it as the dagger-shaped Q waves. And this dagger-shaped Q waves, they are like characteristically seen in from V4 to V6. And in other leads where you can have the prominent Q waves, the prominent Q waves are also seen in 2, 3, and as well as the AVF. Right? 2, 3 AVF also, there can be prominent Q waves. So these will be the ECG changes you will come across in patients with hypertrophic cardiomyopathy. But what is the first line investigation? That will be your 2D echo. So what will the 2D echo shows? The 2D echo, it will show you the presence of asymmetrical septal hypertrophy, right? And you will also identify the SAM, and you can also measure the diastolic dysfunction, right? And you can also calculate the ejection fraction. And you will also be able to make out if there is any systolic dysfunction. Okay. So these are all the things that you will be able to make out by doing the 2D echo. Then the other important investigations are the myocardial perfusion imaging. See, this myocardial perfusion imaging, whenever you do, that will show you the presence of the septal ischemia, right? So the coronaries will be normal. The coronaries, they will be absolutely normal coronaries. But in spite of that, there will be septal ischemia. So why is that? That is because of the septal hypertrophy. Myocardial oxygen demand increases within the septum, but the supply is reduced, and that is what is responsible for the septal ischemia, and that you will be able to make out by myocardial perfusion imaging. The next thing is the cardiac MRI. So the cardiac MRI, it is the one which confirms the hypertrophy, right? Which confirms the cardiac hypertrophy, either the septal hypertrophy or the apical hypertrophy. And when you do a contrast enhancement within the MRI, the contrast enhancement, you will be able to pick up, right? You will be able to pick up if there is any presence of the scar. If there is any evidence of scar, that you will be able to make out by contrast enhancement. Okay. And next thing is the cardiac catheterization. Cardiac catheterization confirms the diagnosis and defines the presence or absence of the coronary artery disease, right? If there is any underlying coronary artery disease, that you will be able to make out by cardiac catheterization. Otherwise, if it is only hypertrophic cardiomyopathy, right, the coronaries should be absolutely normal. Okay. And in these patients with hypertrophic cardiomyopathy, frequently there can be coronary arterial bridging. Right, there can be coronary arterial bridging. Right, so that you will be able to make out by the cardiac catheterization. So what happens in bridging? There will be squeezing of the coronaries in systole, right? And particularly it occurs on the septal arteries, right? So that is about the coronary arterial bridging, and that is the importance of the cardiac catheterization. And another important investigations are the exercise studies. So exercise studies, what is the purpose of it? They are mainly recommended to assess the ventricular arrhythmias, right? That is mainly to assess the ventricular arrhythmias, and also to document the blood pressure response. Okay. So patients in whom systolic blood pressure does not increase more than 20 millimeters of mercury during treadmill, they are at increased risk of arrhythmias and sudden cardiac death. So you take in a normal individual, upon doing treadmill, the systolic blood pressure increases more than 20 millimeters of mercury. That is in a normal individual. But in those individuals, in spite of exercise, if the systolic blood pressure is not increasing more than 20 millimeters of mercury, that tells that this individual is at increased risk of sudden cardiac death secondary to your VT or VF. That is about the importance of the exercise testing. And another important investigation is the loop monitoring. Loop monitoring, it is recommended for the determination of the ventricular ectopy, right? For the determination of the ventricular ectopy you will place the individual on the loop monitoring. So it is implantable loop monitoring, ILM. An implantable loop monitoring, it is a type of heart monitoring device that records your heart rhythm continuously for up to 3 years. So you need to place that implantable loop recorder that will continuously monitor the heart rhythm for up to 3 years, right? And this implantable loop recorder, it will record the electrical signals of your heart and allows remote monitoring by the way of small device inserted just beneath the skin of the chest. That is about your implantable loop recorder. Then, so this is about your investigations. First line will be your 2D echo. The one which will confirm is by your MRI. In MRI, you will also be able to make out the presence or absence of the scar. Now, the next important thing is the treatment in patients with the hypertrophic cardiomyopathy. So you need to be very much aware of giving an important caution or advice to the patient. That is, the patient has to avoid exertional activity. Right? So upon doing the exertional activity, there can be increase in the levels of the catecholamines during exertion, which will increase the contraction of the heart, and the obstruction increases if there is septal hypertrophy. And that can cause sudden cardiac death in the individual. So avoid exertional activity is the first important advice that you should be giving to the patient. Then what are the first line drugs? The first line drugs are the beta blockers. And these beta blockers, it includes either propranolol, which is a non-selective beta blocker, or you can use selective beta blocker, that is metoprolol can be given. And if the beta blockers are contraindicated in case of respiratory pathologies like in COPD and bronchial asthma, we usually avoid giving the beta blockers. In such case, we give non-dihydropyridine calcium channel blockers, which are nothing but L-type calcium channel blockers. And the examples of this L-type calcium channel blockers, they are the diltiazem and as well as the verapamil. So these drugs, they are considered as the first line drugs in the treatment of the hypertrophic cardiomyopathy. Now, what is the advantage of these drugs? These drugs, they will reduce the heart rate in the individual. They will enhance the diastolic filling. So by reducing the heart rate, they will increase the diastolic time. So thereby, there will be increased diastolic filling. And the third important thing is these drugs, they will decrease the contractility. So by decreasing the contractility, right, the obstruction decreases. So that is what is the first line drugs in the treatment of the hypertrophic cardiomyopathy. Then followed by that, if suppose in spite of giving these beta blockers and as well as the calcium channel blockers, if the symptoms are persistent, right? So persistent symptoms of exertional dyspnea or persistent symptoms of the chest pain, they can be controlled with addition of the disopyramide, which is an anti-arrhythmic agent. Okay, if the persistent symptoms are there, then the drug that you need to give is disopyramide. And this particular disopyramide, it is an anti-arrhythmic agent or anti-arrhythmic drug, right? So this is about the medical management. And this disopyramide, it is an anti-arrhythmic agent with potent negative inotropic property. So contractility will be reduced by giving your disopyramide, and thereby the obstruction can be reduced. So this is about the medical management. But in the recent times, there are new drugs which have come up. And what are these new drugs? They are small molecule inhibitors of the actin-myosin interactions. Okay, so by inhibiting the actin-myosin interactions, the obstruction can be reduced, right? They are being developed for obstructive, and not only for obstructive, even for non-obstructive hypertrophic cardiomyopathy. And what are the examples of them? That is mavacamten, that is one important new drug. The other drug is omecamtiv mecarbil. These are the new molecules which are the inhibitors of actin and myosin interaction. But there is slight difference in the mechanism of action between these two. Let me try to explain to you. The first drug is the mavacamten. This mavacamten, like this is a small molecule which will inhibit the cardiac myosin. Right? It is a small molecule which inhibits cardiac myosin. So that is the mechanism of action of the mavacamten. And this mavacamten, by inhibiting the cardiac myosin, that will reduce the contractility, right? That will reduce the contractility, and they will also improve the diastolic function. Right? So that is the action or the use of this mavacamten, right? So by reducing the contractility, what is the advantage? It will reduce the left ventricular outflow tract obstruction in patients with the hypertrophic obstructive cardiomyopathy. And the next important drug is the omecamtiv mecarbil. The mechanism of action is slightly different compared to the previous one. So it is a small molecule activator of the cardiac myosin, right? It is a small molecule activator of the cardiac myosin. Now, in what way this will be useful? If it is activating the cardiac myosin. So this omecamtiv mecarbil, it increases the duration of myosin attachment to the actin. Okay, so what it will do? It will increase the duration of myosin attachment to the actin. That is what is the action of this omecamtiv mecarbil. By increasing the duration of myosin attachment to the actin, it will enhance the contractility without increasing the energy consumption. So it will increase the contractility, but there is no increase in the energy consumption. So that is the advantage of, right? That is the advantage of this omecamtiv mecarbil, right? And what the results have shown from the trials, using this omecamtiv mecarbil, it improved the cardiac function. It reduced the hospitalization in patients with the heart failure. That is the advantage of this, the omecamtiv mecarbil, right? It reduced the requirement of the hospitalization in patients with the heart failure. Now, you take the subsequent treatment in the form of a flowchart. First and foremost, if you're seeing a patient with hypertrophic cardiomyopathy, you need to evaluate the risk of sudden cardiac death. Is it present or absent? Or if the individual is symptomatic or asymptomatic, that is what you have to look for. If the individual is asymptomatic, you just check if the individual is having any risk of sudden cardiac death. If the individual is having risk factors for sudden cardiac death, I'll tell you. What are the risk factors for sudden cardiac death? I'll tell you. So in them, you need to consider the implantation of intracardiac defibrillator, right? And if the risk is low, then just serial evaluation has to be done. And if the individual is symptomatic, then what is the drug that you need to start with? You need to start with the beta blocker or the calcium channel blocker. And if the individual develops the heart failure causing pulmonary edema, right? If there is evidence of the fluid retention, then you need to give diuretics, but with high caution. Okay, you cannot give a high dose diuretic. If you are giving a high dose diuretic, that will induce hypovolemia and it will reduce the LV volume, it will increase the obstruction and it will decrease the cardiac output. So use diuretics with caution to avoid hypovolemia. Right? Now, in spite of giving these beta blockers or calcium channel blockers, if the symptoms are persistent, then you need to look for the outflow gradient. If the outflow gradient is present, then you need to try with an antiarrhythmic drug, that is disopyramide. In spite of giving disopyramide, if the symptoms are refractory, then you need to consider for these procedures, that is septal ablation, that is in the form of alcohol septal ablation, or surgical myomectomy should be done, or the mitral valve surgery should be done. Because of SAM, there can be mitral regurgitation. So mitral surgery has to be done. And if there is no outflow gradient, and if there is evidence of severe progressive LV dysfunction, then you need to consider for the cardiac transplantation. And if there is no evidence of the LV dysfunction, you need to reevaluate the cause of the symptoms. So this is how you need to approach a patient with the hypertrophic cardiomyopathy, right? I'll just give you another approach. like depending upon the obstructive physiology being present or absent. Okay, so this I have given you in general, but you see the other one. So first, if you find that there is a patient with hypertrophic cardiomyopathy, just check whether obstructive physiology is there or not. Obstructive physiology will be there if there is septal hypertrophy, and if there is apical hypertrophy, obstructive physiology will not be there. Now, if there is obstructive physiology, you should avoid vasodilators. The nitroglycerin and all should be avoided, and you should also avoid the high dose diuretics. So the drugs which are contraindicated in HOCM, I was just discussing previously also, the diuretics. High dose diuretics you should not give. Then nitroglycerin, then your digoxin, then catecholamines, they should be completely avoided. Okay, right. So now, what are the drugs that you need to start with? So if there is heart failure or angina, the first line drug will be your beta blockers. And if beta blockers are contraindicated, then you need to give L-type calcium channel blocker, that is verapamil. If the symptoms are still persistent, in spite of giving this verapamil, you need to give antiarrhythmic drug, that is disopyramide. In spite of this, if the persistent symptoms are there, then you need to do the invasive therapy. And if he is a surgical candidate, then what are all the surgical options that we have? Surgical myomectomy, alcohol ablation. And if he is a candidate who does not fit for the surgery, then in that particular group of individuals, pacing has to be done. Regarding this pacing, I will discuss subsequently in detail. What is the advantage of the pacing? All that I will discuss. Okay, right. Then that was the approach in case of obstructive physiology. For suppose there is no obstructive physiology, I will discuss about the pacing subsequently. Just hold on for 2 or 3 minutes. And if there is no obstructive physiology, that means if there is apical hypertrophy, in such case, you need to check for if there is symptoms of heart failure or angina being present or absent. If the symptoms of heart failure or angina are present, then you need to check the systolic function. If the LV ejection fraction is less than 50%, then the standard heart failure therapy, that is your beta blockers, ACE inhibitors or angiotensin receptor blockers, the aldosterone antagonist should be given. And if the ejection fraction of the individual is more than or equal to 50%, then you need to give beta blockers or the verapamil. Then diuretics or ACE inhibitors or angiotensin receptor blockers have to be supplemented. Then you should advise the individual for the annual visit. So this is about the approach depending upon whether the obstructive physiology is present or the absent. Now we were discussing about these procedures. What are the two important procedures if the individual is refractory to the medical management? That is the alcohol septal ablation and as well as the surgical myomectomy. See, what you need to do is you need to inject the 100% alcohol into the septal branches. And these septal branches, they are the branches which are coming from the left anterior descending artery. So for doing this alcohol septal ablation, the very important point that you have to remember is the patient should be having suitable coronary anatomy, right? And only if there is suitable coronary anatomy, then you have to plan for the alcohol septal ablation. And by doing this alcohol septal ablation, that will relieve the outflow tract obstruction by controlled infarction of the proximal septum. So what is that you are doing here is, by injecting the 100% alcohol, you are doing the controlled infarction of the proximal septum. So by doing the controlled infarction of the proximal septum, what will happen to your LV outflow tract obstruction? That will be reduced, right? And not only that, the gradient also will be reduced, right? By doing your surgical myomectomy, the gradient between the LV and as well as aorta reduces, right? The gradient between the LV and as well as the aorta reduces. That is, even your alcohol septal ablation also, it will reduce the gradient between the LV and as well as the aorta, right? But what is the disadvantage of this procedure? Okay, so the most common complication is the development of the complete heart block. Because what is that you are doing, right? You are doing the alcohol septal ablation or you are doing surgical myomectomy of the septum. when you are doing surgical myomectomy of the septum or when you are doing the alcohol septal ablation, what is that you are doing? There is a high chance that you may injure the conducting system which is present within the interventricular septum, and thereby the individual may develop the complete heart block. So once there is development of this complete heart block, then he is a candidate for permanent pacing. So this is what I was discussing, right? The requirement of the permanent pacemaker. So permanent pacemaker has to be placed if the individual develops the complication of complete heart block secondary to alcohol septal ablation or the surgical myomectomy, right? Next, the another important arrhythmia. See, one important arrhythmia is your VT or VF that is coming from the hypertrophied septum or from the scarred part of the ventricle. The next is the atrial fibrillation. Now, why is that there is development of atrial fibrillation is because of increase in the LV end diastolic pressure. What will happen? The left atria pressure increases. So thereby there will be left atrial hypertrophy. And this hypertrophied left atrium will be arrhythmogenic, and thereby the individual will develop the atrial fibrillation. So once there is development of the atrial fibrillation, what is the problem is, number one, there can be hemodynamic deterioration, right? And there can be development of the embolic stroke, right? There can be development of embolic stroke. Now, so why is that hemodynamic deterioration? That is because of the poor supply or poor emptying of the atria to the ventricle. So in atrial fibrillation, the ventricular rate increases. That means your diastolic time decreases. So the ventricular filling reduces. So what is that you have to do now in order to avoid this hemodynamic deterioration? So that ventricular response, that rapid ventricular response, that should be slowed down. That should be slowed down. So how can you stabilize this hemodynamic deterioration? So you have to give beta blockers that will reduce the heart rate, or the other drugs are, you need to give L-type calcium channel blockers that will slow the AV nodal conduction and it will improve the symptoms within the individual. And very important point, usually in the treatment of atrial fibrillation, we give another important AV nodal blocking agent, that is digoxin, which is a cardiac glycoside. But here, in case of this hypertrophic obstructive cardiomyopathy, the causing atrial fibrillation, digoxin should be avoided because it may increase the contractility and will further worsen the obstruction. So digoxin should be avoided, but the other drugs, the beta adrenergic blocking agents and L-type calcium channel blockers, they can be comfortably given. The other point is not only reducing the heart rate, the other important thing that you need to achieve in atrial fibrillation is the rhythm. So you need to restore the sinus rhythm, right? Restoration of sinus rhythm is also very, very important. So how is that you will restore the sinus rhythm is, you need to give the antiarrhythmic drugs, that is disopyramide, and the other important antiarrhythmic drug, which is a class 3 antiarrhythmic drug, that is amiodarone, has to be given to achieve that sinus rhythm, okay? And if this particular atrial fibrillation is refractory to medical management, that is the point when you need to consider for the radio frequency ablation. So if the individual is refractory, then radio frequency ablation of that arrhythmogenic focus within the atria has to be done. And next important in atrial fibrillation, there is chance of the embolic stroke, for which you need to give anticoagulant, that is low molecular weight heparin should be given. So that is how you need to approach the atrial fibrillation in case of the hypertrophic cardiomyopathy. Now, these patients with hypertrophic cardiomyopathy, they should be placed on the implantable cardioverter defibrillator. But you need to know which group of individuals they require the ICD. First and foremost, if the individual has the history of the cardiac arrest or spontaneous sustained ventricular tachycardia, then he is the candidate for the ICD. So what is the screening technique for knowing that there is history of cardiac arrest? That is, the history will tell you. You should ask either the patient or patient attender, like if there was any history of the cardiac arrest or if there was any spontaneous sustained ventricular tachycardia. In them, you need to place the ICD. And if there is a syncopal attack, again, this is also the same thing. With the help of the history, you will be able to make out. So if there is syncopal attack on exertion, he is an ideal candidate for placing the ICD. And the next important is the family history of sudden cardiac death. He is also the candidate for ICD because he is a high-risk individual for the development of sudden cardiac death secondary to VT or VF. Then non-sustained VT, right? This non-sustained VT, like how many beats? There should be more than 3 beats at a rate of more than 120 per minute. More than 3 beats at a rate of 120 per minute should be the heart rate. So if that is there, he is also the ideal candidate. So how will you make out that there is a non-sustained VT? That is, either you make him to do the exercise, right? Either you make him to do an exercise and just check whether there is development of non-sustained VT or not, or you need to do 24 to 48 hour ambulatory monitoring. 24 to 48 hour ambulatory monitoring for the development of this non-sustained VT. Next point is the left ventricular thickness. If the left ventricular thickness is like more than 30 mm, right? So how can you make out that you will be able to detect by doing the 2D echo? So if the left ventricular thickness is more than 30 mm, he is also an IDF candidate for the ICD. Then abnormal blood pressure response on exercise. Right? Abnormal blood pressure response on exercise. See, upon exercise, the systolic blood pressure has to increase more than 20 millimeters of mercury. But if there is failure to increase the systolic blood pressure upon exercise, then in them you should place an ICD. He is a high-risk individual for the development of VT or VF. So how can you make out this? That is by doing the exercise testing. So these are the candidates, right, for implantation of the ICD, that is implantable cardioverter defibrillator. And like, how is the prognosis? See, in the recent days, with the advent of the new drugs and as well as the new techniques, the sudden cardiac death can be avoided. But in spite of appropriate caution, if the individual does the exertional activity in spite of appropriate caution and in spite of advising him to get an ICD done, if he doesn't, then there is high chance of the sudden cardiac death. So who are the patients at risk of sudden cardiac death? Number one, those individuals who have survived sudden cardiac death or past history of VT. Number two, those individuals with family history of sudden cardiac death. Those patients who had an unexplained syncopal attack. Then those patients who have a documented non-sustained VT. Right? Documented non-sustained VT. Just now we have discussed like how much should be VT, like it should be more than or equal to 3 beats at 120 beats per minute, and that can be monitored by ambulatory ECG monitoring. And those individuals with LV wall thickness more than 30 mm. So these are the candidates for high risk of sudden cardiac death, right? In all these individuals, you need to place an ICD. Now, one important differential diagnosis of hypertrophic cardiomyopathy is the athletic hypertrophy. So you have to remember that the elite athletes, they also may demonstrate the hypertrophy of the heart. Right? They also may demonstrate the hypertrophy of the left ventricle. And this can be confused with the hypertrophic cardiomyopathy. But how will you differentiate the hypertrophic cardiomyopathy from athletic hypertrophy is, in patients with athletic hypertrophy, there is no diastolic dysfunction. But in case of the hypertrophic cardiomyopathy, you have the presence of the diastolic dysfunction, right? So this will separate the athletic hypertrophy from the hypertrophic cardiomyopathy. And the athletic hypertrophy, which part of the left ventricle is usually hypertrophied? It is mainly the apical variety, right? It is mainly the apical variety, which is very common. So this is about your athletic hypertrophy. So in conclusion, let me tell you, the criteria to call hypertrophic cardiomyopathy is the LV wall thickness should increase more than 1.5 centimeters. Either it is at the level of the septum or at the level of the apex. So if it is septal hypertrophy, you have an obstruction. For apical hypertrophy, you don't have the obstruction, right? And septal hypertrophy, there is high chance of the familial inheritance, almost 50%. But in case of the apical hypertrophy, the familial inheritance is only 15%. Then the hypertrophic obstructive cardiomyopathy is characterized by dynamic outflow tract obstruction. That is mainly because of the systolic arterial motion. And if you take the pathogenesis, there are 9 different genes which will undergo more than 1500 mutations. And the most common genes that are being mutated is MYH7, that is beta myosin heavy chain, or myosin binding protein C3, right? That is MYBPC3. And the type of inheritance is autosomal dominant type of inheritance. So that is the reason why the screening in these individuals, they have to be started in the adolescent age group itself. And these patients, they are at increased risk of sudden cardiac death upon doing the exertional activity. And when you do the biopsy of the hypertrophied septum, what is that you will observe is, you will observe that there is misalignment and as well as disarrayed myocyte architecture with swirling and branching rather than usual parallel appearance of the myocyte fibers. And what are the various changes that you will see within the heart? Hypertrophy, that is a prime change. Interstitial fibrosis, microvascular ischemia, and there will be also the areas of scar. And in these individuals, it is primarily diastolic dysfunction, and there can be secondary systolic dysfunction as well. And most of these patients, they present with sudden cardiac death. And if at all, if they are symptomatic, the most common symptom will be dyspnea, and the other symptoms will be pre-syncopal attack, the syncope, angina, palpitations, dizziness, and there can be also congestive heart failure. The characteristic pulse will be pulsus bisvarians, double carotid upstroke will be there, double apical impulse, S4 will be heard, and the characteristic ejection systolic murmur is being heard. And how will you diagnose? The first line investigation is 2D echo, and the confirmation can be done by your MRI and as well as the cardiac catheterization. And the treatment, the primarily you need to advise that the individual should avoid the exertional activity, and the drug of choice will be the beta blockers and as well as the calcium channel blockers. And in those individuals who are refractory to medical management, you need to implant the devices in the individual. So this completes the discussion of this very important topic, that is hypertrophic cardiomyopathy. Thank you very much.